Well, we're going to start out slow this morning with bradyarrhythmias, but a little bit of introduction first. We know that, all of you know better than I do, being where you are, that supraventricular arrhythmias are very common in the critical care setting. It comes part and parcel with being sick. A lot of sick people have heart rhythm disturbances. A lot of them are supraventricular. Many of them are related to the diseases that brought them into the ICU setting in the first place. Some are treatment related, and we're responsible for that. That's a little embarrassing. Some don't need any further therapy. Some are, as I said, the reason why they're in the ICU in the first place. So it just stands to reason that if we're going to get this right, we might as well make a right diagnosis first. Everything else follows from there, and if you get that wrong, you get everything else wrong. You might end up with the right answer by accident, but it's better to get it right the first time. One of the things that is primary with these rhythm disturbances is to find if there is an underlying cause and fix it rather than just pouring more medicines or treatments at the rhythm disturbance. And finally, to treat the patient, not the arrhythmia. We get kind of wrapped up into these things sometimes, but it's important to remember there's a patient under there. Now, we're going to look at a bunch of different rhythm disturbances over the next 4 lectures, and with some common themes here. What are their diagnostic features? In what settings do they occur? What is their clinical significance, if any? What do you do about them acutely? And does that impact on long-term therapy, if it's even appropriate to talk about that in certain settings? Lots of tools of the trade that we use very commonly. There's telemetry. And very importantly, recall. We'll see how important it is to see how rhythms start and how they stop. Sometimes you get important clues during those episodes that you don't see during the ongoing episode. The 12-lead ECG, of course, kind of a forgotten art in some settings. ECG calipers. Whenever I get on the service, I start a new day of inpatient service. I ask everybody to produce their calipers. Half of people don't have calipers with them. The other half, you have to, get on a foot and kind of crank it up because they've never been used. These are very useful now. Some people say, well, I just use a tick mark make a mark on the paper. Okay, some way to measure intervals. But it's important to actually measure intervals because sometimes they're very subtle changes, especially if you're looking for AV dissociation. Physical maneuvers can certainly be used. We all have a couple of fingers with us for carotid sinus pressure. It's a useful thing in the ICU setting, sometimes a little bit diminished by access to the neck with lines and so forth. Medications can be used, adenosine, beta blockers, judiciously. And some people have pacemakers or ICDs. That's free information. You can get that out of them. Sometimes you need some help getting that information. We also have therapeutic tools that we can use. We have physical maneuvers again, carotid sinus pressure, et cetera. Medications can give us not only diagnostic, but obviously therapeutic information and benefit. Temporary pacing, transcutaneous, not so much, but transvenous, it's a little bit trickier to do. And then, of course, cardioversion, defibrillation. We'll talk about those to some extent later in the morning. Now, bradyarrhythmias. These are very common in sick people. We see them all the time, and they break down into 2 different categories. Some are due to problems with impulse formation that's in the sinus node, or the sinus node fails and you have an atrial bradycardia. Some are with impulse transmission, that's AV conduction system, mainly. Some are sinus exit block. These are quite rare and quite irrelevant, in my view, in most instances, but we'll talk about them nonetheless. And most of the stuff on this slide is not very important here. There's sinus bradycardia, we all know what that is. Sinus exit block, it's the angels on the head of a pin, really. It's just not that important. For the vast majority of cases, it's really unusual. I have trouble finding examples of that. Sinus arrhythmia, quite common, phasic changes with respiration, the spontaneous respiration, not induced. Sinus pauses, this is the absence of a P wave that is not an integral multiple of the prevailing PP interval, whereas sinus exit block is an integral multiple. Sinus arrest, no P waves at all, just either junctional rhythm or ectopic atrial rhythm. And the one that is important is Brady-Tachy syndrome. Some call it tachybrady. I don't really care what it is. Usually it's the Brady follows the tachy phase. So a sinus pause occurs, sinus node suppression after cessation of a rapid atrial arrhythmia, such as most particularly atrial fibrillation, but others will do. This is a little bit of an unusual view of the heart. There's a fellow named McAlpine who was a surgeon who did some meticulous work on cardiac anatomy and photographed all these in his basement. And this is a view from the septal aspect outwards of the right atrium. So we see here the right atrial free wall with the appendage sticking up here, superior vena cava, inferior vena cava coming off this way, and the right ventricle and the tricuspid annulus along in here. And the sinus node hangs out up in this region here, at the junction of the superior vena cava and right atrium at the top of the crista terminalis. It is not a spot. It is not a cell or two. It is a region. And so sometimes the rhythm comes from way up high. Sometimes it's a little bit lower, even further down the crista terminalis. It's even, you can even get somewhat inverted P waves. It's still sort of sinus rhythm in those cases. It behaves like sinus rhythm. But most of the time we identify it by positive P waves in leads 1, 2, and 3. Now, this is sinus bradycardia. I think we can all appreciate that it is slow, and it is characterized by sinus-looking P waves, positive in leads 1, 2, and 3, and the rate is less than 60, and it's pretty regular. There can be some phasic respiratory variation. Now, this is a disorder that has a context to it. If we see this rhythm in somebody at 2 o'clock in the morning and they're resting and they're comfortable, this is normal, quite normal for physiology. The T waves we can argue about. But for the rate itself and the fact that the sinus rate is so slow, quite normal under those circumstances. If you're trying to run up 4 flights of stairs or some bad guy is coming after you with a gun, this is very maladaptive. So it all depends on the context. And lots of different settings in which you will encounter these: sedation, hypoxemia, high vagal tone, especially if you're putting in a neckline, a little bit of carotid sinus tickling, hyperbilirubinemia in the liver failure crowd. Not an unusual finding with those, and we get kind of vexed about that, but it's a known phenomenon that I don't know why bilirubin affects the sinus node that way. But importantly, ischemia is not a very common cause of this. Now, I know we all rule out an MI, check the markers and stuff like that. Get over it. This has nothing to do with ischemia. I shouldn't say that so definitively. You can get sinus bradycardia with ischemia, but it is never, hear me, it is never the only manifestation of ischemia. They have chest pain, they have ST segment changes or something. This is a distant relative of ischemia. It just doesn't have much to do with it at all. And it's easy to get markers and stuff like that, but let's bark up the right tree instead of the wrong tree and not get distracted by stuff that is irrelevant. This doesn't usually have too much clinical significance unless they get really, really slow and are really, really sick, and your diminished cardiac output results from that. Acute therapy is with the usual stuff. We reach for dopamine, perhaps a little bit better in some settings because of what is causing it, the sedation and so forth with vasodilation. Isoproterenol works just fine, except it's very expensive nowadays, just became that way. Dobutamine works as well. It's a little bit more of a vasodilator. So sometimes dopamine's one of your better choices here. Longer term therapy really depends on what the cause was and how significant it is for the patient's particular illness. A couple of things here about some other variants of sinus node dysfunction. Sinus exit block, where you have a long interval between P waves that is pretty close to an integral multiple of the previous PP interval. It's a little bit hard sometimes because the PP interval, I'm not talking urology, I'm talking cardiology here, the PP interval does change a little bit with phasic respiration. This is a sinus pause here where it's not an integral multiple. Again, sick patients have these sorts of things. They occur in the middle of the night. The nurses get vexed about them. Usually you're missing one QRS complex. It's not going to make too much difference, and so therapy is not really important for this sort of thing. The tachybrady syndrome. Here we are with an episode of atrial flutter or fibrillation, and then it just stops, and the sinus node says, well, I haven't had to do anything for a while because this other atrial arrhythmia is going, and so it doesn't know that it's supposed to, what's my line here? I forgot what I was supposed to do. So there could be a pretty prolonged pause. I've seen 10, 15, 20 seconds in some cases. And then the sinus node just picks up fine. So as long as you can keep people out of this tachy phase, you can keep people out of the brady phase. Common settings are, as we've talked about before, atrial flutter, fibrillation. Sometimes medications that suppress the sinus node are responsible for this as well. And then you end up with the tachy phase, and it's hard to know what to do. The clinical significance of this is really pretty transient in most cases because the sinus node or junctional rhythm does recover, just as a little bit of a pause in there. Acute therapy can be difficult, especially if people are going in and out of this sort of thing, because if you give medications that shorten the pause, you'll probably increase the heart rate during episodes. And if you say, well, I want to suppress the tachy episodes, then you make the pause a little bit longer sometimes. So it may be a little bit difficult to manage this, and if you can figure out what the underlying causes of the atrial arrhythmias and get rid of that, you may be in a better way, hypoxemia or so forth. Sinus node dysfunction with sinus arrest. This is just somebody who's coming along and the sinus node just says, you know, I haven't had a break in a while, so just a pretty prolonged pause. Fortunately, there's a QRS in the middle here, but this is a sinus pause of almost 9 seconds. And it has really nothing to do with AV conduction. This is impulse formation as opposed to impulse transmission. Very commonly, we see this in the ICU setting with suctioning or manipulating an ET tube. A trach or something like that. GI instrumentation can also get it from either direction, and hypoxemia sometimes, and sometimes we have to have atropine at the bedside when people are going to be suctioned to prevent this. It tends to be a transient phenomenon. People retching and so forth can have this as well. Everybody who sees this is pretty symptomatic. Patients are usually not too symptomatic. Avoid causes of it to keep it from happening again, and wait it out. In most cases, rarely will you need pacing for this sort of thing unless they're extremely prolonged pauses, and it's going to be a long vent run for the individual. Okay, moving down the conduction system. Atrioventricular block is quite common in the ICU setting, and it comes in 3 varieties with some subtypes. First degree so-called block is not really block. Everything eventually gets where it's supposed to go, it just is delayed. Secondary block is actually block. It's intermittent conduction with either Wenckebach periodicity, and this can occur anywhere in the heart, in the atrium, in the sinus node, most commonly seen in the AV node. And this is progressive delay of conduction in block. Type 2, Mobitz 2 block, this is Mobitz 1 Wenckebach, Mobitz 2 is just Mobitz 2, and sudden conduction block without antecedent PR prolongation. High-grade block is a subset of this in which we have 2 or 3 non-conductive P waves. It's difficult to classify because we don't see incremental delay in AV conduction intervals. But one way or another, it's just never good. It's always bad, and generally bespeaks worse things to come. And then third-degree block, sometimes not so very bad. Sometimes people have a pretty robust junctional escape, and despite the fact there's no AV conduction, they're doing not too terribly badly. Here's the conduction system again, this time viewed from the outside looking in. And here we see the right ventricle, right atrium, IVC, SVC, aortic root right back there. And the AV node hangs out in this region here between the coronary sinus ostium, tricuspid annulus, and the membranous septum, which is up there, which is where the His bundle hangs out. And just on the opposite side of the His bundle is the aortic root. And we use that to good advantage during our EP studies, trying to figure out how to avoid the aortic root when we're trying to puncture through the septum here to get into the left atrium. But the relevance here is, as we'll see in a couple of minutes, first starting off with this first degree AV so-called block. It's not really block. Everything eventually gets to where it needs to be. But the standard definition is something that's greater than 1 big box on the ECG, 0.2 of a second. Common settings for this are far, far, far more in the AV node than the His-Purkinje system. The longer this interval is, the less likely it is to be a His-Purkinje problem. You can have a lot of delay in the AV node. If you even have a 50 millisecond, that's just a little bit more than 1 tiny box on the ECG, a 50 millisecond increase in the HV interval, the His-Purkinje conduction interval, that's almost pacemaker territory there. So the longer your PR interval, the less likely it is to be His-Purkinje system, the more likely it is to be AV nodal, and therefore if conduction fails entirely, it's much more likely to have a reasonable junctional escape. Calcium blockers, beta blockers, dime a dozen, elevated vagal tone, and this is usually transient because vagal tone is a transient phenomenon. The clinical significance is really, really minimal in most cases. Sometimes you'll have a very, very long PR that is almost, especially if the sinus rate increases, the P wave can be in the ST segment, and then it's kind of like pacemaker syndrome. People get this sensation of bulging in their neck because the atria are contracting against closed AV valves and so forth. That's a really pretty unusual situation for the most part. Acute therapy, not necessary. Long-term therapy, usually not necessary. It's just a non-entity. but people see it and get excited about it. Okay, Winky Bach, or Mobitz 1 type 1 second degree AV block, not so uncommon either, and this is intermittent conduction. There's a single non-conductive P wave after progressive PR prolongation, and you really have to have a reasonably long rhythm strip to be able to detect this. And it is with a relatively regular atrial input. So if you're having a lot of PACs, some of which conduct, some of which don't, it's really hard to call Winky Bach in that situation. It may just be physiologic prolongation of the PR interval. Common settings for this include elevated vagal tone, its effect on the AV node, beta calcium channel blockers. Inferior ischemia can certainly cause this, but not by an ischemic, direct ischemic mechanism on the AV node, but by reflex vagal activation. It has not too much clinical significance. It's a single dropped P wave. It occurs every once in a while, so hemodynamics are not too perturbed by that. If it does progress to complete heart block, which it can do with inferior infarction, the level of block is high enough up in the conduction system that a His bundle junctional escape is usually there, usually reasonably reliable, and so you have some breathing room with that. Most people don't need any therapy for this sort of thing, and it's being a transient phenomenon, it's usually not necessary for long-term treatment as well. But contrast that with, and there's our PR prolongation and eventual block. Contrast that with Mobitz 2 block, which is not superficially a ton different. Here we have a single non-conductive P wave along the way, but there has not been any antecedent PR prolongation, and the first PR that follows is the same as the last one that you saw that was conducted. And again, it's a relatively regular atrial input without a lot of jumping around with PACs. Now this is His-Purkinje disease, far, far and away. Some people argue whether it even occurs in the AV node or not, but almost always when you'll see it as a marker of His-Purkinje disease, most often there is some other indicator of His-Purkinje disease, such as axis deviation or bundle branch block, more particularly the right or left bundle, and it's usually not a transient phenomenon. Usually this is a fixed problem within the conduction system. It's not going to get better by itself. It may get worse and may get worse suddenly. When it does get worse, it's already in the level of your escape intervals, of your escape source in the His bundle, or it's occurred below that. So now, even if you had a reliable escape, it can't get through. So sometimes these folks are in very, very bad shape, and it's worth even considering temporary pacing in these individuals, especially if they can't afford to be missing out on a bunch of QRSs because they're that sick if they go into complete heart block. Most of these people will need a permanent pacemaker in the long haul. And there's our single non-conductive P wave there. High-grade AV block, a subset of this, because we can't see any PR prolongation in many cases. You can't tell whether it's, especially if it's a 2-to-1 conduction, 3-to-1, 4-to-1 can occur as well. But there is some conduction going on, so it's not complete heart block. It's not very good conduction. It's intermittent, but you can't really localize it to the AV node or categorize it as type 1 or type 2. Generally, this is His-Purkinje disease. We would think that because we don't have much of a prolonged PR interval here to begin with, so it's probably not AV nodal. It can progress to complete heart block, often with a poor escape interval, escape rate, and these should also have temporary pacing in the most cases, and usually a permanent pacemaker to follow. And there's our P waves that are non-conductive and then just start conducting again. A very unusual thing. Third degree AV block, complete heart block, no transmission between A's and B's. Again, we have to have the definition correct here. There's no transmission, no evidence of perturbation in the RR interval, which is relatively regular. The PP interval is faster than that, and you have opportunities to conduct, but it doesn't conduct. So that's the definition of that. AV nodal or His-Purkinje disease are roughly evenly divided, depending on your population, maybe more one way or the other. Maybe a transient phenomenon with vagal stuff and so forth, or maybe permanent. If the ventricular rate is too slow, you may have poor hemodynamics and may need a temporary pacemaker, and many of these people will need a permanent pacemaker if it's not a transient phenomenon. So there's P waves. They are not talking to the ventricles not talking to the atrium. Everybody's just doing their own thing. The way things sort out with this, I'm going to leave this to your reading a little bit later. This is just a general guide as to where conduction fails and how reliable the escape rhythm is With first degree, there is no relevance of escape rhythm because every complex gets through and so on and so forth. So I'll leave that to your reading a little bit later. Now, temporary pacing. This is a very important thing that you all can do for your patients, but like anything else that we do, it has to be done correctly to make sure we're not making things worse somehow. Transvenous pacing can be done through an internal jugular approach. It's pretty stable. You can move patients from bed to radiology or GI procedures and stuff like that without dislodging the wire. But most people don't like stuff hanging out in their neck. It's pretty uncomfortable. Families don't like seeing that with their loved ones and so forth. Subclavian is pretty stable, but a little bit more risk of pneumothorax, especially on mechanical ventilation. The femoral approach is pretty quick, pretty safe, but not very reliable. It's easily dislodged and has the risk of deep venous thrombosis. Not so much of infection, I don't think, but we still worry about that. These are importantly not a set and forget thing because the thresholds do change, leads do migrate a little bit without any fixation mechanism on them. And so we have to ensure that it's not only pacing properly, but sensing properly daily. This is something that you can leave to your cardiology friends, or you can probably do yourself if you feel like it. Transcutaneous pacing, it's an easy fix, but it's pretty uncomfortable if the patient's awake. You ought to try it on yourself sometime. I know the reps always do that, and they take off their shirt and they put this thing on and say, crank it up, and they're going, see, doesn't bother me at all. This is feeling great. Okay. Try that for a half hour, and we'll come back after getting a cup of coffee and see how you're feeling about it. You must ensure that you're capturing with this. It's easy to capture skeletal muscle, and if you're feeling a femoral pulse or even a brachial pulse, it feels like there's a pulse wave, but maybe not necessarily that way. The ECG is really blown out in these cases, and you think you're capturing. I had one person who was down in the high 80s of temperature. She'd been dead for a while. But they said the transcutaneous pacing is still working because, I don't know, the ECG was showing it or something. I don't know. So it's best to have an arterial line or a pulse wave that you can tell that something really is working here. Now, talk about some miscellaneous stuff in the last few minutes of this session. Lots of things that can fool us here. We get a lot of consults for rhythm disturbances that aren't really rhythm disturbances. It's something that shows up on the monitor and everybody gets excited about it. Non-conducted atrial premature complexes, quite common. Ventricular bigeminy gives a slow pulse. If somebody's feeling just the pulse and they're an instrument in some other way, the monitor may not see all the QRS complexes because it's isoelectric in those leads. So it looks like they're much slower than they actually are. ECG artifact, quite common as patients are being jostled around in the ICU setting. And then we have some catheter-induced problems. We put catheters in people, PA catheters and so forth. And you can get complete heart block if you have pre-existing left bundle branch block and you come along with a PA catheter innocently enough and bang into the right ventricular septum, knock out the right bundle. Now you've got two problems, the one that you were starting to treat with the PA catheter and complete heart block. This is not so uncommon. We don't have a good fix for that nowadays. We used to have a pacing swan. I don't know if we even do nowadays anymore. I used to find those pretty useless because if you needed it for a pacemaker, it wasn't out in the PA where you could monitor the pressure, and if you wanted it to monitor the pressure, it wouldn't capture reliably. So yeah, it's got all those functions, but they don't actually work in most cases. You can have pauses after PACs or PVCs from a catheter that's in the right atrium or right ventricle that can cause some consternation. Here's somebody that's coming along at 4 in the morning, 4:40 in the morning. It's a pretty good time for critical care folks to be kind of stumbling around the ICU and seeing what's going. And this is a person who's got pretty profound bradycardia, but it's due to premature atrial complexes that are not conducted. And so as far as the sinus node is concerned, I'm doing everything I'm supposed to do. I don't know what you guys are so bothered about. At 4 p.m., I guess it's the day before here, the guy's doing just fine, or at 4 p.m. later that day. So the PACs are gone. Sometimes you'll see this in the T wave. It resets the sinus node discharge rate. You may see the PACs that do conduct, and that's a clue as to what else is going on. This can occur at any time in anybody. There's generally no significance to it. Acute and long-term therapy need to be based on symptoms and nothing else. It has no pathologic significance. This is a pseudo-bradycardia. I'll have several slides of this. This is somebody who, on a pulse tracing, they're not going very fast, but on the ECG, they're doing just fine. This is because the PVC causes the left ventricle to contract before it has adequate filling. Therefore, it doesn't eject very much. But you see that the pulse wave is a little bit larger on the alternate beat. So cardiac output usually doesn't fail too much with this. It's maybe 10% less or so. Most people don't need long-term therapy. If you do, you'd see an electrophysiologist to get rid of your PVCs somehow. So there's the pulse wave that doesn't exist. This is almost isoelectric PVCs in this particular lead. You can see them there. They look a little bit funny. But if you have just the right lead, you may not see these at all and say, why is this patient so bradycardic? Usually no therapy is necessary acutely or long-term for this sort of thing. This occurs not very uncommonly here, and it's usually not too much of a fooler. We see some pretty slow heartbeat up here, but the pulse wave is just fine. So there's something going on. We just don't see it on the ECG. And sometimes you'll see these little disturbances here that signify that there was a QRS or maybe a T wave that wasn't fully formed on the ECG. Sometimes the line between QRS complex is really a little bit too straight to be physiologic. Usually there's a little bit of a slope to it or so. It has obviously no clinical significance, and you just need to fix the ECG electrodes or attach them a little bit better. And no long-term therapy is needed either. Okay, question here. And do we have this for ARS? Yes, okay. All right, so first question. Based on this tracing here alone, is atrioventricular conduction intact? Is complete heart block present? Is high-grade AV block present? Or one of my favorite answers, more information is needed. And do I advance to get to the answer? Oh, all right. What am I looking at? Okay. The bulk of you say AV conduction is intact, and you are correct. If we go back to the slides here, well, I don't know if I know. Okay, we'll just, can you, there, okay. All right, now, this looks like in fact, it is a relatively regular QRS here. We see a P wave in front of the first one here, and this first one, and we don't see so much of it. There's a P wave in front of the second one, but the PR is too short to conduct, so this is junctional rhythm coming along here. But the presence of junctional rhythm doesn't mean the absence of AV conduction. In fact, the clue is way off over here, where we see a P wave that just happens to be timed appropriately, and it conducts just fine, a little bit of a long PR interval. Why is this PR interval longer here than on the rest of them? It's a phenomenon that we call concealed conduction, because this junctional beat, you don't need to know this, just for fun of it, this junctional beat conducts retrogradely into but not through the AV node, so it doesn't get to the atrium, but it renders the AV node partially refractory, such that the next beat that comes through it takes a little bit longer, concealed conduction. You can whip that out on rounds and say, well, it's concealed conduction, and everybody will say, whoa, he knows what he's talking about, or they'll say, what's that? All right, second question. 23-year-old is admitted after an episode of syncope, and he's injured himself in so doing. And so based on the tracing, we usually gauge syncope's importance as whether they injured themselves or not. A lot of teenagers are always having syncope, and they get out of school that way and stuff. And 100 episodes of syncope, never injure yourself. But this is a different one where we're injuring ourselves. And so based on this tracing, what should we do? Continue observing the patient, order serum cardiac markers, get a set of electrolytes, or set up for transcutaneous pacing. Please vote. Wow, you guys are much better than my guys. If we go back to the slides here, we're supposed to just get, all right. This is artifact here, and you can see along the way here, there's an extra glitch along here. Whenever you see this very, very flat, and it's clear artifact somewhere along the way, is over here as well, you got to suspect that the problem section of the tracing that you're looking at may well be artifact also. And so this is just observe the patient. This is not a clue as to anything that's going on with them. Setting up, getting cardiac markers. has no relevance in a situation like this. Stat electrolytes for if they had hyperkalemia here, they probably had it here and here as well, so that's probably not going to be relevant, and transcutaneous pacing has no role here. All right, I think we're just about done with this section. So bradyarrhythmias are common in the ICU setting. They may be transient and they may be benign. They may be harbingers of bad things to come along the way. The ECG can often give you clues as to where in the conduction system the problem is and how worried you should be about it, what you should do if complete heart, what you should be prepared for in case complete heart block ensues. Reversible causes in all of medicine should be sought and addressed before piling on new therapies, and many can be managed pharmacologically, but some do need temporary pacing.